So, my name's Chris Warburton. I'm the Medical Director of the Cheshire and Merseyside Cancer Alliance. I'm a respiratory physician. I work in Liverpool. I'm going to talk to you today a little bit about what cancer alliances do, what they are, how they fit into the National Cancer Programme. So initially, what is the Cancer Programme? This is basically responsible for delivering the long-term ambitions for cancer, which I'll come on to in a second. And the programme consists of NHSE and NHSI, national teams, regional teams, cancer alliances, and everybody involved with those, and I'll come on to what they are in a second. We all work closely together to try and deliver that NHS Cancer Programme. Cancer alliances are the cancer delivery arms of the constituent STPs, or integrated care service systems. We lead the delivery of long-term plan ambitions for cancer for the population, and we provide system oversight and coordination for cancer services. There are also other people involved in doing that. Regional teams from NHS England and NHSI are accountable for a little bit more in terms of performance against cancer waiting times targets and other standards. And there's also a national cancer team who we report to, who are also involved in the definition of the long-term plan and ambitions, etc. So what are the long-term plan ambitions for cancer nationally? Well, by 2028, and you can read this yourselves, an extra 55,000 people each year will survive for 5 years or more following their cancer diagnosis. Additionally, 3 in 4, so that's 75% of all cancer, will be diagnosed at an early stage of their cancer. So what are cancer alliances? Well, effectively, cancer alliances are a number of things. We are a core team of employed individuals who are involved in delivering the long-term plan ambitions for cancer. But effectively, Cancer Alliance is anybody who's dealing with cancer within a population, and for us, that's Cheshire and Merseyside. Our Cancer Alliance geography aligns with the STP, or the Health and Care Partnership. And we have a structure which I'll come on to in a second, but effectively we have a cancer board. In terms of what the planning guidance says around cancer alliances, effectively we are the cancer delivery arm of the STP, and for the Cheshire and Merseyside, that's the Health and Care Partnership. And effectively STPs are where commissioners and providers come together to deliver a system-wide plan for cancer covering core operational performance and transformation. We have a number of functions as a Cancer Alliance, so fostering productive partnerships between members of the STPs, commissioners, etc., specialised networks, and all those things you can see listed there. We set a strategic transformation plan for cancer. We ensure alignment with wider STP plans. We deploy service development funding so that benefits the whole population. We harness data to look at and improve operational performance. And we work closely with our NHS England and NHSI teams to maintain that system-wide overview of cancer services. Cheshire and Merseyside is a fairly complex STP, Health and Care Partnership. We have a population of 2.4 or 5 million, depending on where you draw the boundaries. We have some very deprived areas. We have an elderly population. We have a number of CCGs. We have more providers, probably than most other STPs, and we are one of the larger STP areas. Our Cancer Alliance has a Cancer Alliance board, which is chaired by our Senior Responsible Officer for Cancer, that's Dr. Liz Bishop, who's also Chief Executive at the Glassbridge Centre. There's a Medical Director, which is myself, and we have a Managing Director called John Hayes. Below that, we have a number of program managers and project managers, along with admin support. And we have a very large and involved clinical quality groups. So these are our clinicians who are involved in our groups. These are tumour specific, but also some cross-cutting CQGs, including radiology, pathology, psychology, etc. Effectively, what we are as a Cancer Alliance trying to harness is the opinions, the input from all of the people you see in the green box to the right there. So that's effectively the general population. So anybody with anything they want to wish to ask questions around cancer can ask us questions as a Cancer Alliance. But effectively, we engage with primary care and general practice, secondary care clinicians and tertiary care clinicians to try and influence cancer services across Cheshire and Merseyside. We have quite a big programme of work. I'm going to go through these individually, but you can see there are 7 headings on this slide, including prevention and screening, faster diagnosis, access to optimal treatment, personalised care, research innovation, leadership and patient and public engagement. I'm just going to show you some slides with regards to those individually. In terms of prevention and screening, we're involved in delivering prevention commitments for the NHS long-term plan, and that largely for cancer is smoking, but also obesity and alcohol consumption. There's a programme around HPV vaccination for boys, and also HPV, using HPV as a screening for cervical screening. There's a programme around modernising bowel screening, rolling out fit testing in bowel screening, improving the take-up of low participation groups, and lowering the screening age from 60 down to 50. And also we're involved in implementing the recommendations of Mike Richards' reports around screening uptake, and we work together with public health teams to improve that local uptake. Around faster and early diagnosis, there is a whole policy area around rapid diagnostic services and rapid diagnostic centres. So that's to try and upgrade and bring together diagnostic equipment and expertise as close to patients as we can. There's a new faster diagnosis standard, so everybody who's referred as an urgent referral for suspected cancer should have a definite yes or no. You probably do or don't have cancer within 28 days. We're involved in 3 of our CCG areas now with targeted lung health check programs, and these are programs which are designed to try and diagnose lung cancer earlier. And I won't go into much more detail around that, but you can find information for that on our website. We're involved in Be Clear on Cancer campaigns nationally, and also with primary care around primary care networks and their service specifications around cancer. Around access to optimal treatments, the Cancer Alliance has work programs around genomics, radiotherapy and the radiotherapy networks. Children and young people, there's a new specification around children and young people around cancer, and adopting new innovative treatments more quickly. So you can see there's a couple of examples: 5-ALA for brain tumour surgery, but also CAR T-cell and proton beam therapy for certain types of cancer. One of our main tenets is to try and reduce variation in access to treatments. So we're involved in understanding where those variations happen and what we can do to reduce those. In terms of personalised care and support, there's a new quality of life metric which is being piloted currently and will be rolling out in the next year or 2. There's patient experience surveys, personalised care around personalised follow-up and personalised treatment for their tumours. So there's a big area of work around personalised care and support. We're also involved in research and innovation. There is a new innovation fund which is being tested and piloted, and we're trying to bring innovation through the cancer services much more quickly. Research trials for young people, and then new national plans around research and innovation as well. In terms of leadership and local delivery workforce, obviously we as the Cancer Alliance provide leadership and development for the cancer services generally. There is a national data service called CADIAS. We're involved in operational performance, so trying to recover and sustain 62-day performance in particular, and reviewing standards to make sure they're all fit for purpose. We also have staff who work only in cancer workforce and are involved in trying to make sure cancer workforce is brought up to speed, and we can develop the right cancer workforce metrics. Around patient and public engagement, we are involved in enabling people to voice their views, needs and wishes around cancer, and also have a number of forums with regards to that. So if we think about early diagnosis isn't one thing, it's a number of things spread across all aspects of the Cheshire and Merseyside population, right from population issues through to research and patient engagement at the bottom. But you can see there that early diagnosis is involved with education and training within primary care, decision support tools, diagnostics, safety netting, and in secondary care around communication, rapid diagnostic centres, emergency presentations, etc. And I'll come back to that in a second. So what do we know about Cheshire and Merseyside? Well, we know a few things about Cheshire and Merseyside which are interesting. I hope you'll find interesting as well. We have significant variation between our CCG areas in terms of cancer incidence. You don't need to look at the detail of this, but you're quite welcome to. But you will see that the red line there is the average national cancer incidence by population. And you can see that all but one of our CCG areas has cancer incidence higher than the national average. But you can see again, there are some very high areas particularly to the right-hand side of that graph around Liverpool, Knowsley, Halton, etc. We know that breast cancer incidence in South Cheshire is very high. South Sefton has a very high incidence of lower GI cancers, and Knowsley and Liverpool CCGs have very high incidences of lung cancer. So we know that there is very high incidence of cancers in our populations, but also significant variation from area to area. We also know that lots of cancers can be prevented around tobacco, obesity, diet, and other things. In terms of screening and early diagnosis, we know again, so these are graphs for breast cancer at the top, cervical cancer in the middle, and bowel cancer screening performance. And you can see that performance around all those screening areas are both variable and also in some areas better than the national average and in some areas worse than the national average. A lot of these variations depend on deprivation, and the more deprived areas tend to perform less well in terms of screening uptake. And you can see for breast cancer, areas such as Liverpool, Knowsley are way below the national average. For cervical cancer, Liverpool, South Sefton, Halton, Knowsley, and for bowel screening, same culprits, I'm afraid, Knowsley, Liverpool, Halton, South Sefton. So areas of deprivation tend to translate to areas of poor screening uptake. We know also that the routes to diagnosis for cancers, particularly these are lung cancer on the left and colorectal cancer on the right, are variable. Emergency presentation, which is in the green colour, accounts for maybe a third of all presentations of these common cancers. And so we're trying to work towards reducing the number of patients who present with their cancers through the emergency route. We know their outcomes if they present through the emergency route are much worse than if they don't. We know that stage of diagnosis is also very variable. So you can see here on the left-hand side, for people who present with melanoma, the vast majority of people present at stage 1. But for some of the more common cancers, lung cancer, esophageal, pancreas, etc., the number of people presenting with early stage disease is very low. And this is an interesting graph, which I think has stimulated us to try and think about what we can do about early diagnosis. You can see here that the proportion of people with early diagnosis is very variable from tumour type to tumour type. The ones at the top are the high volume cancers, so lung, colorectal, prostate and breast. The ones at the bottom are less common cancers. But you can see the further towards the left-hand side of this graph they are, the less likely they are to present with early stage disease, so lung cancer, pancreas cancer, esophageal cancer and stomach cancer. In terms of the averages, in terms of early stage diagnosis, currently for Cheshire and Merseyside, you can see that the current status is that around 54% of cancers that are diagnosed at stage 1 or stage 2. The national average is 54%. The Best Alliance, which is in north central London, is up at 57%. So we're nowhere near our target of 75%. If we continue to do what we've always been doing, things won't change very much. So if you look at that's where we are currently, around 53%. We can see that if we do nothing differently, then actually we might get up to around 55% by 2028. We certainly won't be anywhere near the 75%. So what can we do to improve that? Well, we need sustained step changes in performance to try and improve the number of patients who are diagnosed with early stage cancer. If we look at these graphs, you can see that there are a number of cancers where we might be able to do something better. So these are higher volume cancers with a below average percentage in terms of early stage disease. So we should be maybe trying to concentrate on these tumour types, lung, colorectal, prostate, trying to improve the early diagnosis of these tumours to try and improve this. We also know that there is variation within Cheshire and Merseyside in terms of our CCG areas, as you can see as well. We've got South Cheshire there with a 58% early stage diagnosis and Southbourne and Formby at the bottom there with only 48%. So we need to do some work also in CCGs to try and even out that variation and improve the lower ones to the average of the better ones. So we know there are things we can do. We need to be looking at high volume, low performance tumour groups, colorectal, lung, prostate, etc. We need to be looking at tumours where other cancer alliances have higher rates, and that's around bladder, kidney, prostate and ovarian. And we need to be looking at that within CMCA variation, so different CCGs with different early stage rates. So our cancer alliances are all required to submit improvement trajectories to try and improve this. We know that some interventions will have some effect, so we know that for bowel screening, performing FIT testing, etc., will improve that early stage diagnosis by around 2%. The targeted lung health checks I spoke about earlier will improve that by around 1%. And other things like optimal pathways for patients, public awareness campaigns will improve things to an extent. And improving GP referrals to be all NG12 compliant will also improve their performance in terms of early stage diagnosis. But if we do all that, we're probably going to improve things from the trajectory of doing nothing, but it's not going to get us anywhere near 75%. Cancer Research UK put out this waterfall diagram, which you can spend some time looking at. That describes some of the things I've described already around bowel screening optimization, targeted lung health screening, etc., to try and improve performance against getting patients diagnosed much earlier. But you see there's a big group at the bottom where we're looking at supporting timely presentation by the public, so additional things over and above, particularly on cancer, translational research and new things that haven't even been discovered yet are going to account for quite a lot of the improvement we're going to see in the next 7 or 8 years with regards to early stage diagnosis. Finally, I'd just like to say a few words about COVID-19. Obviously, COVID-19 has had a very significant impact on cancer services. We know that a lot of cancer services in wave 1 of COVID-19 were paused. That caused a significant surgical backlog, lots of long waits around endoscopy and other diagnostics. What Cancer Alliance have been doing largely over the last 6 to 9 months, and we're in the second wave now, is to try and recover and restore services, both diagnostic and surgical services around cancer treatment. Part of that has been putting together a cancer surgical hub, which is for each tumour site, ensuring that patients aren't cancelled for their cancer surgery, but these can be done in other sites where there is less COVID pressure. And we've put together an endoscopy recovery group to try and improve the number of patients who have delays around their endoscopies. Overall, therefore, I think that's essentially what cancer alliances are. We are the cancer arms of the STP. We're involved in service improvement. We're involved in recovery from COVID, and we hope to improve a lot of cancer patients across Cheshire and Merseyside.